بسم الله الرحمن الرحيم. بس عشان نبتدي الجلسة. Well, it's my pleasure to welcome you all in this session, and it's my pleasure and honor to co-chair this session with Professor Adil Salah, Professor of Pulmonary Medicine at Banha University, and I welcome you all. I'd like to welcome as well our guest speaker today. He's a well-known authority, Professor Stanley Field. He's a dear friend of mine, and he has a very good and very strong reputation worldwide. Professor Stanley Field is the regional chair, Department of Medicine Atlantic Health at the Memorial Hospital, New Jersey, and United States of America. Professor Field will give us two very important lectures today, and the asthma in the elderly and the non-cystic fibrosis bronchiectasis. So welcome, Stan, in Egypt, and the floor is yours, Stan.
Well, thank you very much, and it is a true pleasure to be here to talk to you about a couple of very important aspects of respiratory disease. I want to thank Tara, first of all, for introducing me, and the organizers of this very important meeting. I think it's a testimony to the university and the Egyptian Society to put together a meeting of this quality. This is my third visit here to Cairo and Egypt, and it's been a remarkable time each time that I've been here, and I've really enjoyed everybody's hospitality and pleasure, and I am looking forward to speaking to you over this next hour. Now, my topics are a bit divergent, and I will use the hour and stop dead on the hour one way or another, and hope we'll have some time for questions and answers. This first talk I'm giving, Dr. Sidney Brayman was unable to come because of some last-minute emergencies, and so this talk was initially his, and some of the cases in here I give credit to him for through this. But the story of asthma in the elderly is not necessarily a unique story, but when we think about asthma, we think about younger children and problems in childhood and young adults. And we don't focus so much on the elderly with asthma. So I'm going to run that story for you in the next 25 minutes or so, trying to understand the idea that this is not necessarily a unique disease in the old, it's asthma. But because of the aging lungs and the aging individuals, we're dealing with a different physiology and a little different story that also has a little bit of a different prognosis. So I'm not trying to create a new disease for you here. I'm trying to give you a new perspective on a disease that we're all very familiar with. So let's start with the history. This is a non-smoking gentleman presented to his doctor with a 3-month history of a nighttime cough, shortness of breath, and wheezing. Because the symptoms occurred at night, older individual, he was given DIG and diuretics, felt to be probably heart failure. Symptoms worsened with exercise and exposure to cold air and cigarette smoke. His examination had diffuse wheezes, and after a short-acting bronchodilator, he had improvement of 25%. So he had airway reactivity in an older gentleman. Is this typical of asthma? Well, paroxysms of wheezing and shortness of breath, symptoms worse on exposure, and symptoms can improve spontaneously or with treatment. So he met the criteria clinically for asthma. But who was this gentleman? Well, he wasn't typical. He was an 80-year-old person when symptoms began. So this is a little bit different. And because of a case like this, Dr. Brayman first published a series, I don't know how large it was actually, it was about 25 or 30 patients, in the early 1990s. So this wasn't a new disease but it was an individual with experience in respiratory disease who looked at this problem and began to characterize it. And so that's the story that we're going to talk about. So after Sid originally published that paper, Dr. Enright published a paper a little bit later where, again, identifying the fact that asthma in the elderly wasn't so odd and may represent up to 10% of cases of asthma overall. So what are the questions we'd want to ask ourselves about asthma in the elderly? Well, what happens as the normal lung changes? So part of the story is going to be going over senile emphysema, kyphoscoliosis, decreased muscle strength. I mean, what happens as we age? Is the pathogenesis different? Is this a more fixed airway obstruction than a more reactive younger individual? And the comorbidities of the elderly affect this disease, and is it a worse prognosis? Those are some of the questions that we'll try and answer along with these things. And one of the other important aspects of aging is the psychosocial and psychological effects of the individual in that age group. And just also think about the problem that the elderly have with coordination of taking their medications. Not the same as in a younger individual. So defining normal in an adult is difficult. We have enough difficulty defining normal in general when we talk about cross-cultural problems and cross-cultural issues, the way the pulmonary function tests were developed. A lot of the standards relate to Caucasian farmers in the U.S. That doesn't have a lot of relevance on the east or the west coast of the U.S., or for that matter to most of the world. But yet a lot of the standards that get used relate to that, particularly for us as well. And in this older population, there are some other difficulties that we deal with. So these are some of the points about the aging lung. There are physiologic changes, kyphoscoliosis, loss of power, stiffness of the chest wall, loss of elastic recoil, all of which by themselves are not asthma. But if you have somebody who develops asthma in an elder age group and has these associated physiologic normal dysfunctions, one might begin to see the fact that this disease could be less responsive and or associated with worsening for a given age group. The next couple of slides are just going to review some of these points that we're aware of, which relates to senile emphysema. Hyperinflation, degeneration of elastic fibers, loss of elastic recoil, dynamic hyperinflation, all are accelerated in the aging lung. Basically, if you just look at that Fletcher curve and loss of lung function over age, even though the lung function for that age may be, quote, normal. Thoracic cage is different. If you look at radiographs of the elderly or what happens to vertebral bodies and demineralization in the elderly, one has age-related osteopenia, osteoporosis, and subsequent debility based on those fractures that can occur in the elderly. Let's look at our second case. This is another 80-year-old individual. She's had asthma for a decade, so she developed it at 70. Stable, primary care physician has been following her. Standard low-dose inhaled corticosteroids and occasional rescue meds. And this is what she looks like. And I think many of us have seen many patients like this, particularly more in women than in men, but this is clearly a problem. And we can understand what happens to that thoracic cavity and the flattening of the diaphragm, which can give one decreased airflow and decreased elastic recoil on that basis alone. So again, this isn't asthma by itself, but this can worsen an individual with asthma. And data that we know, I've just repeated this, that this is an old study, but many patients who are in the 70 and 80 age group have significant abnormalities of their chest cage based on kyphoscoliosis and decreased ability on respiratory function and respiratory muscles, as we've talked about before, in addition to those comorbid diseases that occur in the elderly, not in kids, whether it be stroke, heart failure, Parkinson's, trying to take drugs, etc. So you begin to see the problem that exists in this population if and when they develop asthma. Well, not only is chest wall strength abnormal in this patient population, but peripheral muscle strength is great. Now, we know in COPD, due to TNF and some other cytokines, there are abnormalities in muscle strength as well. This occurs independent of COPD, but just with the aging patient. Muscle myosin is down, alteration in neuromuscular junctions, and these patients have decreased MIPS and MEPS and inability to expire as well. Let's look at our next case. 75-year-old asthmatic woman, non-smoker, 3 admissions to the ICU for severe status asthmaticus. Each time the patient was found by her family and then returned to work. So we've looked at a first case of an 80-year-old presenting out of the blue, thought to be heart failure. Second case representing somebody with a very altered respiratory mechanics who has asthma. And now a third case of a 75-year-old who has severe bronchoreactivity. So in looking at a comparative group done by Connolly, again, these studies are not new, they're over a decade old, the awareness and the dyspnea perception is very different in the young and old. Not only is dyspnea perception different in the young and old, this patient represents that extreme example of someone who let her asthma go so far that she didn't realize how dyspneic she was. She was much more sedentary and ended up in status 3 separate times because of her awareness disability, if you will. So in addition to this dyspnea awareness, the elderly have problems with perceiving bronchoconstriction. J receptor reflexes could be down, cough reflexes are down, and the hypoxic and hypercarbic sensitivities are abnormal in the 70-plus-year-olds as compared to the younger individuals. So there's a host of physiologic abnormalities that add to this story of the elderly asthmatic. Now add on to that the fact that in many of the elderly, stroke or no stroke, perceptions of cough, mucociliary clearance, and some of the beta-adrenergic and cholinergic receptors are not as responsive. Now this is not as well worked out, but there's clearly animal data and some human data that describes a lack of sensitivity at both of those receptor sites, which makes, again, the elderly asthmatic less responsive to the standard therapies that we have. And this is a phenomenon that we have here of the adenylyl cyclase activity depressed in the elderly. There's uncoupling from adenylyl cyclase complex, and although there's a normal beta receptor density, there's a reduced affinity for agonists. So now the story is getting even a little more complicated. So we've got elderly individuals with perception issues, with muscle weakness issues, who develop asthma at a later date. There's one more piece of this puzzle that I'm going to put together, who also now have a decreased ability to respond to the therapies that exist. So it was an interesting observation that Dr. Brayman made in the early 90s to be put together to a nice paper that he finally put together. We talked about mucociliary clearance, and then the whole host of the comorbid illnesses that we just talked about, which are out there: heart failure, stroke, Parkinson's, etc. And then how does one distinguish fixed airway obstruction from COPD or asthma from COPD. This becomes a problem for all of us in the untreated asthmatic over time, which becomes a crossover in this elderly population. And one can have a degree of fixed airflow obstruction, or in the case of the elderly, where there's a decreased beta responsiveness. But we think we can differentiate. But clearly, if you look at that face of COPD today and the different phenotypes, whether we're talking about repeated exacerbators, some genetic differences, but the non-smoking COPD patient, which I'm going to talk about in the next hour, may be an overlap syndrome here, and we just don't know. But these patients clearly have airflow obstruction with the decreased response to bronchodilators. And this just reiterates that, and Bart Celli wrote a nice paper about that in, again, early 2000s. Now, the last piece of the puzzle in this issue of asthma in the elderly is one of atopy. Again, asthma as defined in children that we think about, it's an IgE-mediated disease. We're talking about the same disease here. Different recognition in the elderly, but when looked at in a couple of papers, and this is kind of interesting data, prevalence of positive immediate tests, although not as great in the older population, still exists. So when people think, well, the elderly asthmatic is a non-atopic patient, that's not true. They're less atopic than younger children, but it's also an atopy or an allergic-related disease. And if one has a history of atopy, whether it was earlier and now it's back again, or whether there's allergy, it's a significant factor. And people can be sensitized to autoergens. And that was our first patient, that 80-year-old who presented that way. And this was a study done in New York City, not far from where I live now, looking at cockroach sensitivity. Cockroach sensitivity is a huge, huge cause of asthma, particularly in Spanish Harlem in New York City. So there are pockets. One can actually look at cockroach infestation in New York and follow the degree of sensitivity. I haven't seen cockroaches in Egypt. Do you have cockroaches? Oh, well, okay, yeah. But there are lots of them. I haven't seen any, and there's bed bugs now in New York, so I don't know about that. But I didn't bring any. I was screened at the airport. No bed bug free. But this was an interesting finding. The point again being that in the elderly, there is still that atopic issue and cockroach. This is a New York study, and so I can't tell you what it was like elsewhere. But the fact is that environmental factors are a trigger and are still a significant factor in the elderly, where you wouldn't really think of it. Again, this is worse in kids, but those same symptoms exist in the elderly, although to not as great a degree. Okay, now, so asthma beginning after 50 is more severe and less reversible with remission rates less than 20% for all of the reasons I talked about. The aging lung and the backdrop, these patients have had less treatment overall, less perception, and remission rates rarely occur, and it's a more difficult disease to treat. So now there is a little bit of a difference between the young and the old, and this came from Sid Brayman's early paper that he described in the New York Academy of Science. If you look at this 7-year outcome, it's a very small study, but this was the original cohort that he looked at from his clinical observation, you get a look at the problems that exist. Steroid dependency, over 3/4. Hospitalizations, close to 60%. Heart disease about symptomatic osteoporosis, life-threatening infections. This is from the steroids, and the total remission, none. So it is a more difficult group of patients for many of the reasons that we've talked about. So they require more but the same anti-asthmatic medications as younger asthmatics. Clinical severity is more severe. Life-threatening episodes are more common. But the beauty of being old, our perception of our disease is not as bad. So their quality of life, at least based on some of these early studies, was not as bad. So yet it's a worse disease physiologically, but patients don't notice their disease. So maybe there's something for getting older in that sense. Hard to say, but something we have to look forward to when there's not a lot to look forward to getting older. So it's under-recognized, under-treated. Forgetfulness, we talked about some of that before. Denial in this disease population. Decreased perception. Patients assume, again, when they're more short of breath, it's either heart failure or I'm just getting older. Cost of medications, again, I don't know how all the cost structures work for you here in Egypt. It's become a problem in the U.S. In getting certain medications. Side effects are clearly more common in the elderly, particularly with the theophylline type drugs. And physicians' perception. Basically, we don't think. Again, we are respirologists. I think we think about it. We're not adverse to thinking about this at all. But when patients wheeze, it's either heart failure first for many, many people, and then maybe asthma later, particularly in the elderly. So in conclusion, asthma can occur at any age with similar clinical and physiologic findings as the younger patients. It's often underdiagnosed and undertreated in the elderly. And the etiology of how it begins in the elderly is really unknown. Why all of a sudden one presents at 60, 70, or 80, but it does. It's associated with atopy and or infection or some other environmental factors, just as it would be in a younger individual, and has a worse prognosis. The normal functional changes of aging complicate the disease, not only from non-pulmonary diseases we've talked about, but pulmonary as well. Those comorbid illnesses and the psychosocial effects of aging are very important. But with appropriate care, outcomes can be reasonably good, but persistent, irreversible airflow obstruction is usually the norm. And that is something that I think we have to be aware of when we're caring for these patients. I'm going to stop at this point. We've got a couple of minutes for questions if there are. Thank you.
Thanks, Professor Stanley Field, for this fruitful presentation about asthma in the elderly. And now we are waiting for the second topic, non-cystic fibrosis bronchiectasis.
Yeah, we have time for a couple of questions.
Any question?
Yes. I'll repeat your question. I'll repeat it.
My question is, since anticholinergics are not part of asthma treatment in younger individuals, and these elderly patients with asthma behave somewhat like COPD, would you think that anticholinergics would have a better role to play in this population?
So the question, I'll repeat it, was the fact that anticholinergics could play a role in this aging population because they behave maybe some more like COPD, in fact, for fixed airflow obstruction. I would agree. I think they really might have a role. Now, we're going to be talking about safety in the next hour of drugs for COPD. And, the LAMAs particularly, or even the short-acting anticholinergics,
other second thing is, which is more like a comment, would you like to be conservative with theophylline in this group, or would you like to be conservative with theophylline while treating these patients, or would you use it? Theophylline. Theophylline.
You know, the options have really I'm old enough to administer the opposite as a resident, a patient at night, when I couldn't get an ID. But the young residents, we don't use it hardly at all because of the risk benefit, particularly.
Thank you, Stan. It's a very elegant presentation. Actually, we face with the old people, we face a lot of patients having the expiratory airway collapse. And they are sometimes misdiagnosed, in the late 70s, 80s. And they are misdiagnosed as asthmatics or COPDers. And sometimes we diagnose them wrongly that they have stridor. And when you bronch them, you find that it's a typical expiratory airway collapse. So I wonder, is it a kind of tracheomalacia? It's the weakness of muscles, and that's...
That's an excellent point. I didn't include that at all because I didn't think of it, to be perfectly honest. But I think if you add to the story of the aging individual, I think I should add a little footnote here. Again, kind of observational, not to be public. But I think that is another group, because vocal cord dysfunction is not a major problem for me. For younger, maybe more female issue in the 20s and 30s. But in the elderly, tracheomalacia, although it's not common, clearly could be a difference. And I think that is worthwhile adding to the presentation. Yes.
Thank you for your illuminating talk. The pattern of asthma here in Egypt in the elderly share many points you have pointed out. But what is dominating in our country is that most of asthmatics, they are not pure asthma in the elderly. Usually they are rather chronic bronchitis with airway obstruction, especially because of smoking and air pollution. Another factor is that many comorbidities are present in the elderly patients, and especially with the use of drugs in our country, non-steroidal antirheumatics, etc. This may present in later life as asthma in the first time of their life. Also, many of our patients do not like to take inhalers, and that limits their improvement, and even the facilities are not available for them anywhere. My question is that, do you like that asthmatic in the elderly to be treated in a hospital or in a home? Because here in our country, we are trying to do domiciliary care to the asthmatic and COPD patient. We call it hospital at home. That is my question, because it's quite difficult to have beds to the patient and to look for them in the hospital.
So the question is, part of next question, an explanation of asthma here in Egypt, which is a little different in the way it may present because of some of not just the comorbidities, but clearly because of the air pollution issues and some of this chronic bronchitis separating that out. And we're going to talk about that in my next talk. I think that's an excellent point that really confounds a bit of what we're looking at. But the other thing that is different in the U.S. that I would think here, it's now very, very difficult to get admitted to a hospital in the U.S. I'm not sure you follow what I'm saying, but with insurance and the changes that are going on, I think last night we had a discussion, a very big hospital in New York City closed, the hospital where AIDS originally started out, a big medical center, St. Vincent's Medical Center, closed. People never would have thought that would have happened. Beds are shrinking in the U.S. So to get in now, you've got to be very, very sick. You have to meet certain criteria, and we've got people that check. If you get admitted with an asthma that doesn't meet the criteria, they don't pay for that admission. It's very hard now to get in. So we are very much trying to treat a lot of these at home in using extended care with extended nurse practitioners or individuals that go out and see these patients to keep them away from more expensive treatments in the hospital. And that's a lot of what's happening now with chronic diseases like heart failure, diabetes, and COPD. Those are the major diseases that are tried to be treated in a more home, patient-centered environment in the U.S. Okay, I'm going to begin my next talk now. So my next talk is very different, and it's a talk that I'm going to give you from my experience with adults with cystic fibrosis. Now, that adults with CF is not an issue for you in Egypt. I mean, I'm sure there's some, but it's not the thing you'd be looking for. I mean, it's mostly a Caucasian disease, North American disease. I have some patients who are Jordanian in my practice. I've got a couple Lebanese and a couple Saudis. They're kind of a mixed blood population. And some of these patients are not light-skinned. Some are darker skinned. We have a Hispanic population of CF. It's a genetic polyglot now, with the phenotype being different. But the point of this is that the talk really, for you, it should be lessons learned from CF as it applies to bronchiectasis, because bronchiectasis is a problem in Egypt, and probably a larger problem than it is in the U.S. And yet the experience that I have, and I'm sure it's no greater than your experience, but the experience at least from treating a very focused disease like CF has led to a lot of evidence-based data that doesn't necessarily translate into non-CF, but I'm going to kind of throw out a lot of information for you. And again, I don't know how much time we'll have to discuss, but I'll do my best to open it to discussion as well. So the prevalence in the U.S. is probably irrelevant to you. And we have a lot of difficulty getting the numbers in the U.S. But the reason we try to do it is because developing drugs for bronchiectasis is pharma's issue. So they want to know how many people they may have to eventually treat, to know how much money they can make. I'm not being denigrating to any pharmacy people, but I mean that's the reality of drug development. It relates to how important it is to their developing drugs. So what many of them did, they tried to develop drugs for cystic fibrosis and got the drugs developed on an orphan drug status, and then tried to expand it to a non-CF population. So this number is very small probably compared to what exists in developing countries and or a country like Egypt, where there's a lot more respiratory infections that go less treated or more tuberculosis. But be that as it may, it's still a significant number. Now I'm going to take you through this slide. I'm going to take a couple of minutes with, and then I'll rush through some others. But if you look at the pathogenesis of bronchiectasis, in CF, of course, you're dealing with a genetic defect. Well, there's other genetic defects that can cause this, immotal cilia, Young syndrome, other problems, as well as the abnormality of immunoglobulins. This is a dextrocardia patient, as you can tell, who's got cartageners. And then once the genetic defect is there, there's a ciliary dysmotility, transport's abnormal, and then airway secretions become abnormal. Now in CF, the secretions themselves are abnormal. In most of the other diseases we're dealing with, they're not abnormal. Either way, we're dealing with an abnormal airway surface liquid problem. And that surface liquid problem has an infection-inflammation component. Whether it's infection first, inflammation first, doesn't really matter. What matters is what we're treating when we're dealing with patients. Because what happens, of course, is we're dealing with an infected, pooled, puddled airway that is difficult to treat with mucus plugging, tissue damage, respiratory failure, and eventual bleeding. And each of these steps has some theoretical therapies associated with them. So ACT, which is basically airway physiotherapy, whether it's cough, whether it's a chest vibrator, and we'll talk about those modalities a little bit later. How do we treat thick airway secretions? How do we liquefy those secretions? How do we treat inflammation? Are aerosolized steroids of any value? Are macrolides some value? Again, we'll talk about some of those. And then the big thing that's come up lately, and that's kind of a focus, particularly in the CF world, that I think will have some relevance for non-CF bronchiectasis, is aerosolized antibiotics. And so that's been a big push by pharma. And now there's 2 approved aerosolized antibiotics out there. One is aerosolized tobramycin, and the other drug is aerosolized aztreonam. And this is a study from the UK, from the Brompton, looking at the different microorganisms associated. And the important aspect of non-CF bronchiectasis is if you've got bugs that you can't treat easily with oral agents. And the only anti-pseudomonal oral agent we have are the quinolones, Cipro particularly, Levaquin probably as well. But if you look at the data, probably about 1/3 of the patients have Pseudomonas. Now in the CF world, it's about 75 or 80%. So it's a much higher degree of Pseudomonas around biofilms and a different kind of pathophysiology. But here, we're still dealing with a significant number of patients. And the other issue was the different kinds of causes, which I don't want to spend much time with now. But this helps us think about the differential diagnosis when we're going through this disease process. Now, one of the questioners brought up here, this is a big problem in the U.S. as well as elsewhere. Cough and sputum production is the hallmark of bronchiectasis, but it's also the hallmark of chronic bronchitis. So how does one differentiate the two based on history and some of these other findings? And the best and easiest way that we have now, and it's been so much easier since we have high-resolution CAT scanning. So if you just look at a differential and how to go about an approach to this disease, it really can become reasonably simple if one thinks about the disease process, looks at basic studies initially, looks at a high-res CT, normal, abnormal, and then goes about a workup based on the CAT scan findings, sputum microbiology, and one can deal with making a diagnosis with a few simple tests of immunoglobulins, AFB. Again, genotyping may or may not be relevant to this audience. Alpha-1, ABPA, aspergillus can be another possibility, and some of these rarer forms for some of these other patients. Let's look at our first case here. This is a 35-year-old woman with primary ciliary dyskinesia, recurrent sinus infections, lung function about 50% are predicted, with frequent exacerbations despite chronic maintenance therapy. CAT scan, as you can see, with bronchiectatic changes in the middle upper lobes, sinus disease as well. And what are the goals? Well, the goals are bronchopulmonary hygiene, without a doubt. And that is a major factor. It's kind of what we call the ketchup bottle method, really trying to get out and improve mucociliary clearance in a disease that makes it very difficult If there's an underlying condition, to treat that. If it's localized, surgical treatment does make some sense. But antimicrobial or anti-inflammatory therapy is the hallmark of this disease. Acute exacerbations actually are the easier part. When patients get hospitalized, it's kind of like treating a pneumonia. And the choice of the antibiotic is usually based on our antibiograms, what's known at our hospitals or what's available. And usually we can treat the acute infection because it's IV therapy and it's aggressively done in hospital. The bigger issue is chronic maintenance for these patients. And what's the guideline or what's the magic for chronic maintenance therapy? And here, there is no standard, none. I reviewed a large document that the European and British Thoracic Society put out last year. It must have been about 85 pages, lots and lots of information, but very, very little evidence. It was a lot of what we think, how to, and they've got a lot of experience actually at the Papworth and other places. Di Bilton, Margaret Thatcher have done a lot of work, but nevertheless, and they've got a lot of work also with aerosolized antibiotics that are non-approved that they've used empirically over the years. And so these are the main antibiotics that have been used over time in some rotating manner with some other data on inhaled steroids and macrolides. I'll present some of the data. I'll kind of run through it. It's iterative in a way and for the basis of time, but know that there are studies out there, all small, some randomized controlled, many not, but they're mostly small studies really looking at more in the pilot study of chronic macrolides coming from a pan-bronchiolitis in Japan, or in the CF world, again, looking at chronic macrolide therapy, which acts as an anti-inflammatory, whether it has to do with Pseudomonas flagellar ability to attract and hang into the airway, whether it has to do with decreasing neutrophil attraction. In the case of CF, it may be biofilm formation. It's unclear, but what is known is that there does seem to be some immune modulation of macrolide therapy, 500 milligrams, 250 to 500 milligrams 3 times a week, but not well studied in non-CF bronchiectasis. But the other problem with macrolides is mycobacterium and the fact that it can create resistance, particularly in endemic areas. And again, concern for masking non-tuberculous mycobacteria, and there is data on quality of life improvement, but we have speculation that it may or may not help, but that's about it. Now, the big advance that's been made has been targeting therapy directly to the airway with antibiotics. Now, this is not new therapy, and I don't know how many of you in the audience have used aerosolized. Have many of you used aerosolized antibiotics at all? Yes. Your own compounded drugs or gentamicin? Okay. So gentamicin is reasonably cheap, easy to formulate, but not studied in any, pharma way. I mean, there's lots of data out there, but the only approved aerosolized antibiotic now in the U.S. or in the world, I guess, approved from an FDA type, has been this aerosolized tobramycin and this new drug, Caistin, which is a Gilead product, aerosolized aztreonam, a monobactam. Those are the two. And what's very nice about whether it's gentamicin, colistin, or whatever else is compounded is its targeted delivery, enhanced airway deposition. And this is some data from an early TOBI study that we did. It's obvious, but if you just look at it, giving an IV, you get mean peak TOBRIT levels, looking at that 6 to 10 micrograms per mil for the MICs that you want to get, avoiding toxicity. And with an aerosol, you get very low levels, really causing no toxicity at all. Whereas when you aerosolize tobramycin, look at the levels you get in sputum. Hundreds of fold above the highest you can get in serum. So you can deliver now an agent that essentially you'd have no MIC problems with. We can talk about resistance later or other concerns you may have, but it's pretty obvious if you just can deliver that degree of drug directly into the airway, resistance patterns don't matter so much. You can deliver great amounts of drug into the airway and theoretically clean out a problem that's an endobronchial disease anyway of bronchiectasis. You're not getting systemic effect, and so you're not getting all the toxicity. So that's the background that really enabled this whole plethora of aerosolized drugs to take off. And there's lots of studies looking at the different agents that are out there. New agents are coming along. There's Cipro, and there's dry powder drugs that are out there as well that are antibiotics. So that's the background of really where we are. There's fluoroquinolones, amikacin, azetrianam, gentamicin, tobramycin, colistin, fosfomycin is a new drug that Gilead's put out as well. And the studies are there. I've just listed a couple here with gentamicin that Dr. Seplet was talking about that have shown improvement. And that's used probably more worldwide because it's less expensive of an agent. And because of the levels that you get, gentamicin works reasonably well in some of these patients. Now, in trying to develop the drugs to be used as antibiotics, there are two issues to be looked at. One is decreasing exacerbations or time to next exacerbation, or improving overall symptoms during a given time. There are two ways to develop clinical studies that went about. And all of the clinical studies that have been done in large scale, I've got 3 quick slides I'll run through, have basically failed to show enough improvement for big pharma to go ahead with studies. And the reason for that is there have been adverse events at about 20% or so of increased cough or wheeze in the adult populations. So because of that, even though there's been improved quality of life, there's been some improvement in pseudomonal density, there's been some improvement in time to next exacerbation, all the things you want to look for. Not very robust improvements, but some improvement, enough to want to use the drugs. There have not been enough data because of the adverse event profile. And that's the problem in further development of some of these agents right now in the U.S. that's stalling progress for use beyond cystic fibrosis. And that's the result of the next 3 slides I'm going to show, or 4 slides. So this study was the one that we did, which was a large placebo phase 2 double-blind using your basic Toby formulation for a month. Proof of concept was there. Patients felt better. We didn't really look at FEV when it wasn't a primary endpoint, but there was this adverse event of drug relation, even though patients felt better. Then there was other studies that were done, open label, uncontrolled, following 3 cycles. Again, patients felt better, but subset drug-related adverse events. And the adverse events were cough and wheeze. I mean, patients, even though they felt better and did better, there was this adverse event profile that made it difficult. Then the one study that looked at exacerbations, this wasn't published yet. This was presented a couple of years ago at the ATS, was a very poorly designed study, unfortunately, which basically showed that Cipro and Toby was no better than Cipro and placebo. Well, these were only in patients who had Cipro-sensitive Pseudomonas. So unfortunately, they couldn't get the study through the FDA to design it in a way of looking at resistant patients. And that was unfortunate, so that study was not very helpful. Some data on anti-inflammatories. I'm going to move through this because of the time that we have left. I want to go through some of these other agents that are available, bronchodilators, mucolytics, and hyperosmolar agents to liquefy secretions. I don't know how much time you spend with your patients with bronchiectasis trying to get them to do chest physiotherapy, but we have home care companies that go out and work with patients and families to go over positioning. We use many of these relatively inexpensive, particularly the Flutter and the Acapella device in the U.S. to try and mobilize secretions. And we now have approval for the high-frequency oscillating vest. There's not a lot of data differentiating chest clapping from vest, but this is at least paid for now through insurance in the U.S. Is this available here? The vest? No, okay. The vest is expensive. It's about a $15,000 piece of equipment that gets leased back to families. But we use it in the hospital as well. And there's certain guidelines to get to use the chest. So there is data on mannitol and hypertonic saline that comes from the CF world that is being used. There's little bits of data on guaifenesin, potassium, bronchodilators, acetylcysteine, and the other drug that is used routinely is pulmozyme or rhDNase, but the only double-blind study that was done in non-CF patients showed no improvement. So we've got two very good drugs that have been out there for CF. One is an aerosolized antibiotic, Toby, and the other is pulmozyme. Neither has been shown an advantage. However, many of us use them because in selected patients they work, and they work well. But the problem is, and it's not a problem, if there's an adverse event, patients just wheeze, you stop the drug, you don't use it. But in 75% of patients, they will be of some value. But they're not approved, and so they're not paid for in the U.S. So bleeding is a problem, embolization is important, surgery is an issue, is a transplantation again, if it eventually gets to transplantation, and then treating the underlying condition if it exists, particularly with concerns for TB or MAI that are out there. Alpha-1 is not a major problem, and probably is not a big problem here as well. There are many drugs on the pipeline, as I've pointed out. Again, these agents are liposomal antibiotics and dry powders that are available in capsule form, just like in a HandiHaler, that will be available shortly. We've been doing some studies on them now for, again, these are more CF to hopefully be used in non-CF and other clinical trials looking at hypertonic saline. There's a registry now of patients worldwide looking at non-CF bronchiectasis, trying to get enough patients, and they exist very much outside the U.S., and that's part of the problem in getting all the communities to work together to look at some of these agents that are there to study. So there's no approved therapies for non-CF bronchiectasis, that guideline I talked about, although many are used, non-approved. The CF therapies don't necessarily work, and if they work, you've got to look at the selected populations. For maintenance therapies, the question is, which ones, when, how, and why, and how to either decrease exacerbations or keep patients stable. And there's a lot of burden of therapy on the patients. And the last part of that is there are new inhalation devices along with the dry powders that are going to make it easier to deliver. This new Parry device delivers aerosolized antibiotics in about 2 minutes. The old nebulizers were about 20 minutes. So this burden of treatment is a huge difference for patients. And then future directions, as we've talked about, individualization, organism-targeted approaches, and really trying to get some traction on these clinical trials, realizing these are not homogeneous patients. They're a heterogeneous group, and it makes it again difficult to know how we're targeting our therapy based on that. High-resolution scanning has at least made it easy for us now to really go about an organized approach to deal with these patients. I think I'm going to stop at this point and leave some time for some questions at this juncture. Thank you.
Thank you very much, Professor Stanley Field. And we'll now open the discussion. And before we start the questions from the floor, I have a question.
Yeah.
Is there an effect of aerosolized antibiotics in non-CF bronchiectasis on the formation of biofilm in those cases?
Yeah. So the question had to do with biofilm formation and aerosolized antibiotics. Basically, I don't think so.
Yeah.
Biofilm formation is independent of the antibiotic use. And so I think once biofilm is filmed, the antibiotics have no effect on it at all.
Thank you. Any question?
Yeah.
Yeah,
Introduce yourself and ask the question.
Mohan from India. We do have a lot of bronchiectasis, especially due to tuberculosis. So, there are two types. The very simple ones and the ones which are extensive. What would you suggest? What would be the, ideal antibiotic for these kind of people? Because ciprofloxacin,
Right. So
bromycin.
I always start with the most benign antibiotic that will do the job, whatever the job is, realizing that the microbiologic flora that gets coughed may or may not represent all the deep. And so if Pseudomonas is in the airway, it's more difficult from the beginning. But even then, depending how sick the patient and how diffuse, I may try a drug like Augmentin or even a cephalosporin just to change the microbiologic flora. But they don't last very long, and they're usually not that helpful, and one has to begin going through the more difficult. That's why the history was always rotating antibiotics, trying this, trying that. It's a difficult problem.
That's a main problem with us because every time the flora changes, every time. That's why I just ask you.
Yes. Yes.
Yeah, so bronchial lavage. Yeah, so I have experience with bronchial lavage with antibiotics or not in cystic fibrosis, and it's disastrous. It's bad. Patients do very poorly.
Tobramycin as well?
In non-CF bronchiectasis, I don't have any experience, and I haven't done it. But the reason it probably doesn't work is if you just think about the anatomy, and you're dealing, with deep-pocketed bronchiectatic lesions, you're only brushing the top with that antibiotic. And what happens frequently is there's an inflammatory reaction when you start pushing that stuff down there, and patients don't do so well. So I don't do it. Yeah. Yeah, more problems. Yeah, so.
The mic, please, Kumar, the mic.
We did it in the old days. We did that, Stan, and with the gentamicin.
Right.
And as the gentleman said, it didn't work.
Yeah, it didn't work. I mean, it makes sense to the non-respirology doctors. Non-pulmonary doctors say, you got a scope, get down there, suck that stuff out, you'll make them better. But it doesn't work. But you have to convince them of that, or show them some autopsy specimens of the lung, which looks like a sponge filled with deep-pocketed pus, and they realize you can't
Yes,
get
Professor,
to that.
Professor Atif.
Yeah.
Thank you. عاطف القرن أسيوط Upper Egypt. Please, we don't have nebulized gentamicin available at Egypt in Egypt till now. What's your opinion about, as some people may do, sometimes use intramuscular preparations for nebulization? What is your opinion about using gentamicin intramuscular preparations for nebulization? I know that this might not be quite scientifically question, but we might find this in a real situation. Thanks.
So you're asking about using a...
We don't have the solution suitable for the aerolized gentamicin. He is asking, can he use the solution for intramuscular injection in the
You mean
nebulizer?
intravenous injection?
Intravenous
Intravenous.
injection.
Yeah, that's
for-
the one that's used. Yeah, that's the
Yes.
one you're talking about. Yeah.
Okay.
Yeah, we've used that one. Yeah, we take the powder and mix it up with saline and aerosolize it. That's how colistin's done. And in the U.S., now in the U.S. we have these compounding pharmacies that will compound any of the drugs they use for IV. I'm not recommending that. This is off-label. I don't know, but people do it, and maybe it'll work in a difficult case.
It has to be diluted. It's 1:3.
Right. It has to be diluted about 2
If it
to 5
isn't,
cc's.
sometimes you may get into trouble because of
Right.
Oh, so you have an experience in this.
Yeah, we have done it.
Yeah.
And because when tobramycin was not available, we used to use it. We went through the literature, called a lot of people, discussed with a lot of pharma people also. We found that if you dilate it, 1:3, it does seem to work very well. But as I told you before, in a case of post-tuberculosis bronchiectasis, it doesn't work at all.
Okay. Thank you very much. Thank you very much, Professor Stanley Field and all the audience. And we shift now to the next session on COPD. So we'll invite the chairpersons and speakers to come to the stage.